We'll start our IC on a comprehensive approach to managing ocular trauma. Trauma is something that every ophthalmologist we have to deal with in our day-to-day practice. It is really, and each case is very, very unique. There are always challenges that you may or may not be prepared for, and you really have to think on your feet. And this IC is all about giving some few tips from cases that we've seen and surgical methods that we may have used, and also to try and see how we can put it all together to understand trauma better. We will covering the entire spectrum of trauma from anterior segment, posterior segment, nerve injuries, orbital injuries, and medico-legal aspects, and a little bit of AI thrown in. So without further ado, we will start our IC. We'll start with the first talk on surgical management of corneoscleral tears.
So our Chief Instructor, Dr. Sharon herself will be talking on surgical management of corneoscleral tear. Again, she needs no introduction. So she's a veteran cornea surgeon. She's practicing at Narayan Nethralaya, Bangalore. So over to you, ma'am.
Right. So corneoscleral tears can be, across a wide spectrum of size and difficulty, and we always need to have a few things that we assess before we plan it. One, of course, is the nature and mode of injury. Whether it is, what kind of injury, is there any other associated systemic injury there? These are medical legal cases, so the documentation has to be extremely clear and as pictorial as possible. If you have a photographic documentation, it helps. Of course, the patient's vision, whether it's a closed globe, open globe. So there are so many different things that you have to assess. Always look to see if there's any intraocular foreign body, because sometimes that may change our management. And of course, what all is involved. So not only the anterior segment, but always look at what all is involved. So very, very small or a partial tear, we need not always have to suture. But if it's a full thickness tear or a very deep, large tear, shelving tear, tears in children always need to be sutured. In the immediate phase, when we're looking at if it's an open globe, please avoid any topical medication. Start the systemic antibiotic. The most common antibiotic that we start is still oral ciprofloxacin, the age-old medication, but it works very well, very good intraocular penetration. So that is there. A tetanus toxoid injection is also useful, and shield the eye before you plan surgery. Most of the instruments that we need for these surgeries are already available in our OT, so nothing extra that we would require. The sutures we most commonly use for corneal suturing is a 10-0 nylon. However, for very large tears or if there's tissue loss, you may have to use thicker sutures, sometimes 8 or 9-0. And of course, a conjunctival or a scleral tear would require an absorbable suture like Vicryl. Usually they would be spatulated needles, so most of the time it's the same thing we do. The goals of a corneal tear repair is, of course, a watertight closure. That's the first goal, because we want to keep the globe intact. However, in that attempt, it shouldn't be over judicious, so that it's so tight that it causes a lot of astigmatism. So we want to try and maintain the contour as far as possible, unless there's a tissue loss, in which case you can't help it. Restoration of as normal anatomy as possible, and in that case, as much of visual acuity as you can, and further complications which can be of infection or other complications, as we'll discuss. Techniques are very simple, and we've all seen this before. One is, of course, when you are entering the needle or putting in the needle. That's with any corneal suturing. You want to keep the needle as perpendicular as possible so that you get a good depth, because if you're very superficial, then you'll get a lot of cheese wiring and also not get a good opposition edge to edge. Try and get an equal length of the suture on both sides, and this is only changed if it's a shelving tear where we are trying to make it unequal on both sides. The zones of compression is something which is very important to remember. So this basically means that each suture has an effect which is across a rectangular area of the cornea. So you have to imagine that when you are placing your sutures, there's going to be some overlap of those triangles, and that's how we space our sutures. But very simply put, basically you start at the limbus, Then if there are any landmarks, if the tear is jagged or has a particular shape, then you're going to put, and I'll show you in some videos, you're going to put the sutures at the landmarks first and then go in between and put the sutures. So the reason being that this will help you get as close to a normal anatomy as possible. If you do not suture the landmarks first and just start from one end and keep suturing, sometimes there may be a misapposition of a particular area of the cornea. As I was saying, if it's a perpendicular wound, then you want to have it equal on both sides. However, if it's a shelving wound or an oblique wound, then one edge, you'll be closer to the where it's starting shelving and deeper where further away when it's away from the shelving. Zigzag wounds are some of the most difficult wounds, and as are stellate wounds. So there are different techniques for suturing. One is this, where you're trying to put a mattress suture. You can also have cross sutures on the wound. So I'll just show, looks like a very, very small tear. So the first thing that we do, if it is a corneoscleral tear, is explore the area where it's entering into the sclera, because you're doing a peritomy to see the scleral end. Reposit any iris that may be there. Put the limbal sutures. Now this looks like a very small wound, and once the iris is reposited, you start suturing. But once you actually explore the wound, you will see that actually it's a very, very jagged wound. This was a glass injury, and so there were multiple jags at different areas. Not to be daunted by something like this, but you just have to, very patiently see where the breaks are and keep putting. The point in these kind of injuries is that there will be a lot of edema at the site of injury, so you have to put longer bites to try and avoid it cheese wiring. The iris may keep prolapsing, especially if it's an older injury, the patient has not come immediately, so the iris will have a memory which will keep coming. If it's a day-old injury, we do not need to abscise the iris. It can be reposited. However, if it's an older injury, then we may need to abscise the iris to avoid this thing. Now, one case which I wanted to show, which this gentleman presented to us, which was quite tragic, where he had a nail which fell into the eye while working. This eye was no PL at presentation. Very, very important. Even if you have an eye which has no visual potential, still our primary aim is to try and restore globe integrity as far as possible. Primary evisceration is to be avoided as far as possible. Otherwise, always try to restore anatomy where possible. In such cases where you're suspecting an IOFB or you already have an IOFB, imaging is mandatory. So if the patient cannot afford a CT scan, you can still get an X-ray, and still medico-legally it is okay. But wherever possible, if it's a really bad injury, we want to see the bony edges, the bony markings, then you have to do some form of imaging. So here, it was a nail which had gone into the eye, so we really want to know, and obviously from the look of it, a very large nail. So you want to know if the orbit margins, the roof or back is intact, because if it has penetrated through the orbit, then you can't, the removal is that much more tricky. We have to involve a lot of other specialties, including neurosurgery. But here and get an official report, and here the orbital margins and bony orbit were intact. So it's a no PLI. So this is the technique which we can do. However, if there was vision in this eye, then this would have been much more tricky, because you can't just pull out a nail. So the first thing to do was that we couldn't even put in a speculum, so we had to gently just clean it. And you can see that it's a really, really large nail which has come out. It was almost 3 inches. You then go ahead and explore the wound. The corneal wound was fairly straight, but what I wanted to show here was the posterior extent of the wound, because the nail had traversed posteriorly. And the idea is to try and explore the wound and find the posterior extent, which is not always possible. In this case, even the lateral rectus muscle had got disinserted, and which is why I could actually retract the globe to the side and find the posterior extent as far as possible, and then reinsert the muscle. Now, even though it is not an eye which has visual potential, our idea is to give as much cosmetic or globe integrity as possible, and this is a painstaking procedure, but it is gratifying that we may be able to keep this integrity. And this is the patient post-op. You can see that the eye still looks quite well maintained. However, the chance of sympathetic ophthalmitis is very, very high in such cases, and it has to be warned to the patient. So always tell them that, otherwise they'll get complacent and not come back. So you have to tell them that the other eye can have a problem, and they have to come back and check for it. Removal of sutures can be done in the outpatient department, fairly easy. Posterior segment trauma. Dr. Purna Chandra is a senior consultant in the Department of Vitreoretina Surgery at Narayan Nethralaya. He has vast experience in managing these cases and also has extreme interest and experience in retinal dystrophies and management. Thank you, Dr. Purna.
So good morning everyone. Thank you Dr. Sharon for the opportunity. So I'll just try to cover some of the basic aspects of the managing, taking care of the posterior segment when you people encounter with a case of trauma. So in case of an open globe injury, there are different zones which can be involved in a trauma. So as long it is confined to the zone 1 and zone 2 as it is seen in the diagram, it can be handled by an anterior segment surgeon. Once it extends to zone 3, it's always better to involve a retina specialist. So similarly in the closed globe injury also there is a classification, there is different zones of injury. So, but most of the time it's not an emergency condition. You can give the primary treatment to handle the anterior trauma in terms of traumatic uveitis and all that. But it does require referral to a vitreoretinal surgeon irrespective of the zone of trauma. Even if it's in the anterior segment, there could be some transmitted effect which can cause posterior segment problem. I'll explain the same. So the mechanism, what happens in closed globe injuries, there could be coup and counter coup injuries. Coup means the initial force caused directly by the trauma. Counter coup is because of the transmitted shock wave. In closed globe injury, what happens is there will be compression, decompression, overshooting and oscillations. So whenever there is a compression, so once it comes back to the normal position, it is not always a benign event. The reason being the vitreous is relatively inelastic and cannot stretch when the eyeball is rapidly decompressed. So that's where most of the problem happens, and this vitreous will start pulling on the retina and can cause bleeding, the other problems. Fine. So this was a 21-year-old male who presented to us with a history of blunt trauma. So he had a kind of opacification which is confined to the posterior pole. So this is one of the most commonest posterior segment change what we see after a blunt trauma. This is commercial retina. When it is limited to the posterior pole, we call it as Berlin's edema also. It is characterized by transient gray white discoloration or opacification, may be confined to the macula, or sometimes you can notice a cherry red spot mimicking a central retinal artery occlusion also. So the symptoms are usually determined by the location. So the course and management, usually there could not be any visual complaints if it is not involving the posterior pole. As the retinal opacification resolves, the vision may return to normal, and it tends to recover in majority of the cases, except in this severe macular involvement with other associated problems. Otherwise it's a benign thing. Most of the time without any treatment also it can resolve. So the second case is an interesting, the 28-year-old male with history of firearm injury. So he was in a function where they traditionally they fire the bullets, and some bullet passed next to him. He doesn't know how it passed and all that. So this is a typical case of chorioretinitis clopiteria. It is a distinct closed lobe injury, typically caused by a transmitted shock wave of a high velocity missile penetrating the orbit, grazing but not perforating the sclera. Okay, it's all because of the transmitted shock wave. So one clinical feature immediately following the injury, there could be acute vision loss, extensive retinal and choroidal hemorrhage as well as tears in these layers. The sclera always remains intact. The pre-retinal and vitreous hemorrhages are often present. The lesion heals with or without development of a fibrous scars. So how do we manage? It looks very bad, ugly. Once we see that there is a lot of pigment release, the retinochoroidal ruptures and all that. The primary goal is with the clopiteria is to make a prompt and accurate diagnosis. That is more important. You should not get confused with a occult rupture. So despite the lesion striking appearance, only observation, no surgical intervention is the appropriate initial management. You should not do anything. Once you are sure the globe is intact, no intervention. So pars plana vitrectomy may be indicated in case if there is a vitreous hemorrhage which is not clearing. The prognosis obviously depends on where this lesion is passing. If it is excluding the macula, there are cases who have recurred up to 20/20 vision also. Okay, because most of the times the choroid and retina, they retracts at a single unit, so it doesn't allow retina to detach. They heal by scar formation. So this was again one more 32-year-old with history of blunt injury, blurred vision. It's like a spotter. You all can see that there is a macular hole in the center where we can see here. The traumatic macular hole is relatively a common complication after a contusion related injury, may occur within hours of incidence and believed to account for fewer than 10% of all macular holes. The incidence could be around 1.4%, and it always happens in closed globe injury. Open globe injury, usually we don't see macular holes unless it is complicated by some other things like PVR formation and all that. And traumatic macular hole usually typically ranges in size between 0.2 to 0.5 disc diameter, and this is how they look. Most important thing is these are most of the time young patients and the PVD is absent. So the pathophysiology of this hole is different from what the idiopathic macular hole what we see in old age. For the same reason, the management is also different in traumatic macular hole. The hole occasionally may close spontaneously with complete recovery of visual acuity, and 50% spontaneous closure is seen in children. The younger the age, the better the closure rate. Okay, so the moment you see macular hole, it doesn't mean that you go and do a vitreoretinal surgery and try to close, especially in traumatic macular holes. So in adults, the spontaneous closure rate is little less, but it is possible. So this was a 17-year-old boy. He came to us with a history of stick injury 1 week prior to the presentation with a vision of 6/60. Other eye was normal. This was the traumatic macular hole. So this is 1 week post-trauma, and this is 1 month post-trauma, and this is 2 years later. It has closed on its own spontaneously with a good recovery of vision. So whereas the second case was a 36-year-old, followed by an RTA, he had a macular hole, traumatic macular in the better eye. Otherwise, he was already lost to some other trauma. So the vision was 6/60. When we examined, in addition to the macular hole, if you can see there are a lot of pigmentary and scar formation surrounding that. And these kind of macular hole, usually they don't close. So this is the corresponding OCT, and this requires a prompt referral to a VR surgeon, where we did a vitrectomy, ILM peeling and gas injection. So post-operatively, the hole did close, but vision acuity did not improve to a great extent. It remained at 6/60, but over years, they may tend to improve up to 6/24 or around 6/18. So coming to the vitreous changes in blunt trauma, which is the commonest cause for referral to a vitreoretinal department, it could be disinsertion or hemorrhage. Disinsertion can happen because of the vitreous base avulsion or optic nerve or along the retinal blood vessels. The commonest changes are avulsion of the base of the vitreous with or without dialysis, PVD with retinal tear, or a vitreous hemorrhage. So whenever you see a pigments in the vitreous, it's an indication to carefully search for a retinal dialysis or a tear. It's a thumb rule. The moment you see pigments in the vitreous in a trauma, you have to rule out associated retinal break. So vitreous hemorrhage can occur from various causes. In case of closed globe injury, it could be because of retinal tear, posterior vitreous detachment, scleropeteria, optic nerve avulsion, cyclodialysis, iris tear. It could be, the cause could be anything. The moment you see the vitreous hemorrhage, it's very difficult to determine from where the blood has come. It could be because of this. And prognosis also depends on what's the root cause for vitreous hemorrhage. It has happened due to optic nerve avulsion, obviously you can't do much about it. So when you do a B scan in vitreous hemorrhage, the traumatic vitreous hemorrhage will always have a uniform dot echo throat. There won't be compartmentalization like subhyaloid hemorrhage and all that, which happens in proliferative diabetic retinopathy. So the pattern will be little different. So how do you manage this? So associated with closed globe injury, vitreous blood usually managed with close observation is spontaneous clearing of the blood. That's what we do. Usually wait for minimum 1 month for it to clear. But in between, warn the patient about the possible complications. We do vitrectomy only in case of there is an associated retinal detachment. It fails retinal dialysis. So this is basically a suppression occurring at the anterior edge of the ora, more common than generally perceived. So most frequent traumatic retinal break as compared to another retinal break almost always occurs at the time of injury. Unlike this, vitreous remains attached to the posterior edge of the dialysis. That's why usually the chances of RD and PVR formation are less. prognosis is relatively better compared to other form of breaks. And that vitreous attachment is probably the reason for the slow progression in case of this dialysis. So detachments, even if it occurs, are seldom bullous, usually smooth, thin and transparent. The star folds or other proliferative vitreoretinopathy changes are very rare. The features of chronicity are very common because they could remain asymptomatic, and it usually carries a good prognosis. Management, as I told, in the absence of any retinal dialysis, this thing you can just do a laser cryopexy, cryoretinopexy or a laser, barrage laser. Barrage laser is most preferred as compared to any other form of treatment because the chances of complications are less. So occasionally dialysis will seal spontaneously also because of the vigorous chorioretinal response or an insult. So early recognition of the dialysis is the key in avoiding and more extensive intervention. Associated RD, we usually do a scleral buckle in most of the cases. In rare cases where it extends to the macula, if there is a total detachment, you do vitrectomy. Otherwise, most of the time it will settle with the scleral buckle itself. So coming to the peripheral retinal breaks, the common source of post-traumatic detachment, the location and the configuration of the fluff U tear tends to mimic those associated with the spontaneous PVD, something like this. So the symptoms could be a floaters, photopsia, blurred vision, primary or secondary vitreous hemorrhage. So depending on what is causing the symptom spectrum could be different. The retinal detachment in case of horseshoe tear is much greater as compared to the dialysis which I just described. In most cases, the contusion related tears are located inferotemporally. The reason being the bony orbit affords less protection in this area and eye is rolled upwards due to Bell's phenomena associated with impending approach of a noxious stimulus. For that reason, usually this break tends to be more in the inferotemporal quadrants. Management, again in most cases traumatic tears should be treated with laser retinopexy. It's not like dialysis where you have an opportunity to wait and watch. The moment you see the tears, it requires an intervention either in the form of barrage laser retinopexy, and cryopexy is less preferred. So holes that have undergone spontaneous closure due to chorioretinal adhesion can be observed sometimes. So one more case example, this was an adult with history of injury with stone. You can see some concentric semicircular whitish opacification in the macula. So basically this is a choroidal rupture. So this can be two types, direct occurring at the site of impact or indirect away from the site of impact. The indirect ones are always located near the macula due to tethering effect of the optic nerve. Usually these tends to be concentric to the optic disc. So the prognosis of the injured eye can vary. So maybe initially poor due to overlying hemorrhage, improves as the hemorrhage resolves. If it's a subfoveal rupture, obviously vision tends to remain poor. If it's extrafoveal, patient can maintain 6/6 vision also. So treatment, if there is an associated submacular hemorrhage, you can observe, or sometimes we can do something called pneumatic displacement, where we inject 0.3 cc of 100% C3F8 without dilution with paracentesis, and patient is advised to maintain post position for 2 weeks with minimum of 6 to 8 hours per day, with or without tissue plasminogen activator. So this is the post treatment. It is completely resolved with the flat macula. So coming to the last part, just 2-3 more slides. So intraocular foreign body. So intraocular foreign bodies account for 18% to 21% of the open globe injuries. 50 to 88% of post-traumatic IOPs resides in the posterior segment. So young men constitutes about 92 to 100% of the patient, and 66% have average age between 21 to 40 years. The common place, obviously workplace is common, followed by home. The commonest cause in 60 to 80% is hammering. If the patient comes with a trauma and he gives an history of chiseling or hammering something, always with a breach in the eye wall, always suspect an intraocular foreign body. Even if your B scan is not able to pick up, to be safe medico-legally, if you have time, get a CT scan done. Okay, so most of the time patient may tell, no, andar nahi gaya, it fell off and all that, but still you need to rule out the intraocular foreign body. So the appearance, immediate, there could be scleral wound, bleeding, cataract, retinal breaks, or endophthalmitis or inflammation. The later on, it may develop into a retinal break leading to detachment and proliferative vitreoretinopathy, glaucoma, metallosis like sidrosis in case of iron foreign body, hypotonia, all those things can happen. When you do a CT scan, you need to be aware the kind of suspected foreign body. If it's a glass foreign body, usually, sorry, if it's a metallic up to 0.5 mm, it can be easily detected. Whereas in case of glass, the detection rate is 96% if the size is more than 1.5 millimeter. If it is less than that, it's only 48%. That is, still there is 50% chance that you might miss a glass foreign body on CT scan also. So B scan signs of foreign body, you're all aware, like echo dense signal corresponding to the foreign body, the way you can see here. So the persist at low gain, high reflectivity on A scan, shadowing posteriorly. So the size less than 0.5 millimeter may not be produced shadowing. So sometimes in case of open globe injury, then associated air bubble can get confused with the IOFB. You can differentiate by, air is usually regular and spherical. You will have similar echo appearance and moves with the head tilt, and if you follow it up, it will get observed. Whether it's not the same case with the foreign body. So when do you remove the foreign body? You do an early intervention that is less than 24 hours if there is a signs of endophthalmitis, retinal detachment, toxic intraocular foreign body in terms of copper and all, or one-eyed patient. Delayed repair in case of life-threatening other associated injury, if there is an inert IOFB, if there is no endophthalmitis and corneal clarity is poor, and if there is a lack of settings, you can operate later. So this is the last slide, and this is the video showing the giant metallic foreign body. So we do vitrectomy. First thing is we have to mobilize. I have not included many surgical videos because it may not be appropriate to this forum. So first you need to mobilize the foreign body by clearing all the membranes, attachments and hemorrhage around the foreign body. Then engage the foreign body. So these type of large foreign bodies are difficult to remove through the entry wound, that is scleral wound. You may have to do a lensectomy, and better to remove it through the corneal route. So you can use magnet so that you can align it to the cornea or where you want to extract. So this, as I told, we are extracting it through the cornea itself, and this patient, the mode of entry was also through the cornea. There was a cataract, it was easy. So otherwise you may have to sacrifice the lens and extract it. So to conclude, I would like to say it's very tricky when it comes to posterior segment trauma. The prognosis can range from, so completely a normal recovery to a PL negative. So, but medical legal aspects are very important, and prompt reference to a particular specialty, either neurophthal or a retina specialist, very important. Thank you so much.
Thank you very much, Dr. Purna. That was really a comprehensive coverage of posterior segment trauma. I'm sure everyone in the audience also has so much experience, and you'll agree that each case is so different. Any questions from the audience, or a case which you would like to discuss or ask anything about?
Whether the globe is collapsed, is there any very big foreign body? That's all you are trying to do. Just fill the entire thing with the gel, just place the probe, and just if you get an idea, that is more than enough. And if you are suspecting a foreign body, in case of open globe, B scan is not the way to confirm. Better, go for a CT scan. And again, it's a tricky thing. If you can get the CT scan very fast, then do it. Otherwise, we have seen patient will be going around getting the CT scan report and all that. By that time, the eye would have gone for panophthalmitis. So first thing is to close it as early as possible. That is also important.
Yeah, please. Please ask. Do we have a mic? You can take the mic, doctor.
In an open globe injury, if the injury is very severe and there is a big scleral perforation, but the posterior extent of which is not found, it's beyond equator, what should we do?
So you will, you want to take?
It does happen. Most of the time, blunt to injury ruptures, posterior may not be traceable. In these scenarios, I strongly recommend to disinsert the rectus. So once you disinsert the rectus, most of the time you will be able to, reach the posterior extent. So that's the only way. Otherwise, what happens without disinserting the rectus? If you try meddling it, you will be, applying more pressure on the intraocular content. It may expulse out. So disinsertion, if you have a squint colic, it's well and good. Otherwise, you yourself can do it. It's not very, here we are not going to recess, resect, measure, squint aspect. Just cut it at the insertion, keep the temporary suture, and resuture it to the sclera. So that will, because the prognosis here, we are not worried about patient develop squint or not. We have to close it. So I strongly recommend to disinsert the rectus depending on the quadrant in which your stare is extending.
Yeah, definitely what Dr. Purnachandra said. So unless you have, if you have not reached the posterior extent of the tear, then you know for sure that there's going to be a leak and that eye will definitely go into a phthisis very, very early. So yeah, disinserting is the way to go, because it helps you also to be able to retract the muscle or turn the globe so that you'll be able to reach it. Otherwise, it's very, very difficult. In spite of doing all of this, sometimes you may not be able to reach the globe, and those eyes would already have a very poor prognosis. Counseling is key in these cases, and we all know most of these cases will come with multiple attenders, they'll come with so many people around. So counseling has to be very, very detailed and multiple times over, and still after surgery they will come and ask, will we get vision? We have all seen those situations. So you just have to keep reiterating, consents have to be very, very clear, documentation has to be very clear, and we'll have a talk on that as well. But yes, from your side, whatever you can do in surgery. We'll move to our next talk.
So next will be Dr. Sumit Lane, needs no introduction. He'll be taking us to an approach to orbital trauma and fractures. It's important to understand that injuries are not only focal. Many times it involves cornea, sclera, could be an orbital fracture. And how do you approach such a case is what he'll be taking us through. So over to you, Sumit.
Thank you, Gairik. Thank you, Sharon ma'am and AIOC for including me in this IC. I will be talking on an approach to the orbital trauma, and ma'am told me to keep it strictly case-wise. The whole intention of the presentation is that by the end of presentation you should understand what you should not miss when you see a case of orbital trauma. So I started searching for the incidence, but there are very rare studies which talk about the orbital fracture incidence as such. The incidence of the ocular trauma is around 4 to 5%. And especially in the RTAs, the incidence of the orbital fracture is maximum compared to the anterior segment trauma. Now, orbit anatomy all of us know, but these three things are very important as a structural point of view when we are talking about the orbital traumas: is orbital rim, orbital wall and orbital apex. So very first you need to understand the mechanism. The very old theory is the indirect injury or the buckling theory, where there is a blunt trauma on your orbital rim. Nothing happens to the rim because the rim is very steady and strong, but the buckling happens to the floor, which is one of the weak portion of your orbital floor. Second is a hydraulic or the retropulsion therapy, again which says that there is a blunt trauma and there is a displacement of the orbital contents which suddenly try to pop out through the weakest portion of the orbital wall, which is orbital floor as per the theory. But all of us know that the weakest portion is the medial wall, lamina papyracea, and it should break away. But it does not happen, and the explanation for that is having a ethmoid bone which buttresses the lamina papyracea, and it prevents for being the most common site of the fracture with the blunt trauma, and the floor becomes the most common site of the fracture. Now let's go case wise. Now you see a 50-year-old male, most commonly we see in our residency days a raccoon eyes kind of a picture, and when we see this looks very ugly and it becomes very difficult to understand what to do imaging and start explaining the guarded prognosis to the patient. The most important is you take a vision and the pupillary reaction and you advise a CT scan. And you will come to know that everything is only preseptal, there is no orbital involvement, no bony involvement, and the prognosis is very good only with the conservative RX. Now one point I would like to highlight here is when you advise a CT scan, do write that what are you advising it for. It's better that you mention everything every time, even if your radiologist is the same. It's 1 millimeter cuts, axial plus coronal sections, with sagittal reconstruction, with contrast, especially in cases of trauma, and please mention Hounsfield unit in case of mass, foreign body or whatever, if they find incidentally or you are suspecting, and do write indication that what do you want to look for. If you see RAPD, then do write that you are looking for optic nerve avulsion in this imaging. Now this is another case, 20-year-old male came with the history of reckless bike accident. We told him to get the imaging done and get admitted. Patient was not so willing. Patient went home. Again, I got a call in the night that there is one patient came with the trauma. I said so many traumas in a day. Then I realized it's the same patient came with the increased proptosis. Now the same patient you see who had a trauma in the morning comes back in the evening with the increased proptosis. What could be the cause? Can anyone think about it? trauma happened, and after 24 hours, after 12 hours, sorry, suddenly there is increase in the proptosis. So somehow we could see the pupil is getting dilated, retina still seems okay, and when we do the imaging, here is the answer. So whenever there is a trauma, there could be fracture, and now the orbit and the sinuses are connected to each other. So forceful coughing, sneezing, everything can suddenly have a gush of air inside the orbit, and your proptosis suddenly can increase. And that might cause orbital compression syndrome altogether. And this is orbital emphysema. This is very old classification. Still we follow the same classification, and accordingly the management depends on the how severe is your orbital emphysemas. Most common treatment what we do is lateral canthotomy and cantholysis, which is the easiest way. You can do bedside as well. Sometimes orbital decompression is needed. In between treatment is needle aspiration. Now needle aspiration becomes very difficult to see a imaging, and then you see that where do you want to insert your needle and find the air. So easier way to do that is you take a syringe, fill with the normal saline, remove the piston behind, and let your needle, hypodermic needle, pass as per your guidance of imaging. And once you start seeing the air bubbles, that is the point where you can have your orbital emphysema and the aspiration can be done. This is just to highlight that whatever is the case, the vision, documentation, pupillary reaction is the must, howsoever bad is the patient. Now this is 12-year-old boy with the history of eye pain. Sorry for the excessive cropping. He was complaining of eye pain since last 15 to 20 days. Parents ignored, saying that he don't want to study, so he is complaining. Finally they went to pediatrician. Pediatrician sent to ophthalmologist. On evaluation we realized that there is deficit in the elevation in the left eye. Of course we went ahead with the imaging, and this is what it is. It's a white blowout fracture. It is a white blowout fracture, which is very common in the young individual, and they may not come with the pictures of a red color, congestion, diplopia. A child may not complain of all this. Now why this trapdoor kind of a fracture happens? Now all this mechanism the same what we discussed in our first slide. One thing that you need to understand, this is just because the walls are much elastic compared to the elderly individual, and the wall recoils faster than the content, and it does not allow the contents to go back. So once you are into the sinus, and the doors are closed. That's why patient comes with the only deficit, and there are no other symptoms patient may present with. Now this is from my friend Dr. Adit Gupta. This is just to highlight the same point. Again a young patient complains of eye pain, diplopia. Again presentation is delayed, and when you see the adduction is limited. The adduction is limited, and vitally patient has a pulse of only 40 beats per minute, which is again a little not so common in a younger individual. So when we do imaging, we see there is a medial wall fracture. And this again to highlight the importance of the force duction test. Before planning your surgery, or at least on the table, or patient is cooperative in your office, you should do force duction test to know the restriction even before you plan your imaging. Now post surgery patient improved. This medial wall fractures are again to highlight there are two important things whenever you suspect a medial wall fracture. Always measure an intercanthal distance. All of us know intercanthal distance more than 35 millimeter is nothing but telecanthus. Why does the telecanthus happen? It happens because in any medial wall trauma there are high chances of disruption of the medial canthal tendon, and once the medial canthal tendon is destroyed, the intercanthal distance will increase, and then you have a picture like this. This is very important when you want to do a repair of the any medial wall fracture. First thing. Second thing is you need to look for imaging very carefully, because this patient will have a damage to the nasolacrimal duct. So even if you correct the fracture and everything, patient will be keep coming to you with the complaint of watering. So later in the time they will need a DCR surgery along with the intubation, which will last maybe for 3 to 4 months altogether, and not like a routine DCR intubation. Now taking ahead from this point, one more case where a 40-year-old male present with the history of trauma, eye pain and the watering, and once you do imaging you see there is a orbital roof fracture. We take a call on this, medial wall looks fine, patient got operated, rest of the conservative management, everything well, but keep coming to us with the persistent watering. Now, there is no nasolacrimal damage, still patient has watering. Can anyone see what is the cause here for the watering? So, many of you may have seen these cases. If not, then what happens? This is very well reported. There is cerebrospinal fluid which leaks as a tears. And this is nothing but oculoria. Like your CSF rhinorrhea, this is oculoria where the watering happens, and this is basically a CSF. Patient may complain with the complaints of giddiness along with the watering. And the diagnostics, all of you know, do a diagnostic beta-2 transferrin fixation, which will come ahead with the diagnosis that what are you looking at is a CSF leak, nothing else. Many of the times managed conservatively. So this is to summarize everything in the 2 slides, that you do a clinical evaluation, your anophthalmos, trismus, orthoptia, FDT, sensation, and the CT scan comes in the end. So to evaluate everything, if you see carefully, everything can be done. Everything can be done in your office setting. The point is, when you see a case of orbital trauma, the documentation, consent, everything is important. But like your LASIK patient, like your other premium IL patient, you need to give a more chair time. These cases also need a more chair time for your own evaluation, more than talking to a patient, so that you don't miss anything, and the most of the diagnosis is done on your office itself. These are indication of repair. Don't go ahead with all the indications. Only remember 2 things: patient presenting with the bradycardia, patient coming with the bradycardia, and the white-eyed fracture need a urgent repair. Rest also need a urgent repair, but they can be till the patient is fit between 2 to 3 weeks. But having a oculocardiac reflex is an urgent indication to repair your orbital fractures. Just to conclude that it's a multi-system trauma, you may not get a isolated orbital fracture always, so you need to involve a other specialist in this. Adequate use of imaging, clinical evaluation, but do mention that what are you doing imaging for. You need to expect something from the imaging, proper consent, explanation to the patient and the relatives. Generally, we want only one relative with one patient, but if such a case of orbital trauma comes, do allow all the relatives to sit with you and explain them at one go. Otherwise, every time a new relative will come and keep asking you the same question, it will be difficult for you to explain them same thing again and again. And documentation is a must pre and post operatively, whether you operate the patient or you don't operate the patient. Thank you all for patient listening.
Thank you very much, Dr. Sumit. That was a wonderful collection of cases. Our next speaker is Dr. Anand Vinekar. Dr. Anand is a consultant in the pediatric retina department. Of course, is known for his amazing work in ROP. But more importantly, he also has a degree and a background in law. And today, he'll be putting on that hat to teach us about the medical legal aspects of handling trauma cases. Over to you, Dr. Anand. We'll take questions regarding your talk. Dr. Sumit, it was excellent. We'll take it after this.
Thank you, Sharon. And it's a pleasure to be part of this IC on trauma. It's unique. It gives me also an opportunity to learn something new. This is not legal advice. My degree doesn't allow me to be a lawyer. This is just experience that I've collected to share with you. And these are my sources and my teachers in NLS. So I'm going to talk basically about historical aspects, important to understand the legal aspects. Then more importantly, as an ophthalmologist, what should be your first step to protect yourselves from liability of medical legal trauma? What to do next? How to store the records? How long to store the records? When can you be called into the court of law? How would you depose as a witness or an expert? And finally, a checklist. Okay, so historically in literature it's been around, but probably one good landmark article is more than 200 years old now, in 1900s from the US, and then there are other more closer to home, Egypt, and then in India as well. So I've based some of this on the larger studies only in terms of the clinical profile of both rural and urban medical legal trauma in our context. So males are unfortunately 75%, and that's because almost all the cases are associated with some sort of an assault or injury, but the mean age can be as pediatric to about 75. And fortunately, it's only bilateral in 15%, 85% you're still dealing with one eye. The most common injury, at least from a legal perspective, is still a closed globe injury, but out of the open globe injury, penetrating eye trauma is most common. As you can see from a study from rural North India, farmers and laborers constitute to more than 70% of cases, and males can go up as high as 90% plus. In rural areas, you are more likely to see trauma cases in the district hospital. They don't come directly to the ophthalmologist. But if you're practicing in a city or a tier 2 town, from literature at least, you're more likely to be seeing this patient first, even if it's a case of polytrauma. And so that's really important because you might be facing these situations. 90% of cases that eventually reach you with ocular trauma will require surgery. And over 90% of those who require surgery will eventually have legal blindness. So you can already see this is catapulting towards medical legal issues. If you're working in a rural setup, the most common assault is because of firearms, but in urban, it's still a fist injury, physical direct harm. Now, what are the first steps that you'll need to take? Even if you're dealing with polytrauma, you have to stabilize the vitals. There are two landmark cases in the Supreme Court. One is called the Parmanand Katara, which makes it mandatory for all doctors, irrespective of their specialties, to take care of emergencies. And the second one is called the Good Samaritan case, where you are absolved of liability if you have taken care of the case, did not know what to do after that as a specialist, and referred it to a higher center. So these two become both your duty and your responsibility as healthcare professionals. Of course, if it's only ocular-related trauma, the buck stops with you, and it's not a case of polytrauma. So now, who can make the medical legal case? You should not assume that it has to be done by a government hospital or a government doctor. Private doctors not only can make it, they should make it. And if you are the second doctor seeing this patient after some colleague has referred it to you, you will have to make a fresh MLC. Remember this is still mandated by law. And you must inform the police in case of a medical legal case, and medical legal cases have to be made even if the patient or relatives say, I don't want to make it an MLC. This is also important. Irrespective of what your hospital protocols are, this is what is accepted in law. And failure to do so is a violation of IPC 201. Writing this in your record of an accident register as alleged history, because it's not proven till it's proven. And store the medical records as per the law. Currently, it's either 3 years or 7 years. We'll talk about what kind of data there is. And then you must have access to the close by ambulances and emergencies if you are transporting such a polytrauma case. Next, how will you be deposing before law? You can depose either as an expert for opinion, that is either your case or somebody else's case, or the law says that you come here and tell us how much compensation has to be paid for this injury case. So these are the kind of reasons why you might be called by court of law, either as the first doctor, treating doctor, expert opinion, or to calculate the negligence. Now, civil matters and criminal matters, they are equally important. Criminal matters, there are two, that is injury during assault, of course, a fight on the road, or trauma during workplace. And these two are slightly different for us to know, so let's talk about that. Now, when would you require to give a trauma or a wound certificate? These are the 4 conditions, either under the Employee Compensation Act, that is obviously workplace trauma, or if somebody is filing insurance reimbursement, or under the Consumer Protection Act, if somebody has filed a case against the primary doctor, maybe against somebody who has hit them, or an accident, and so on. And finally, if the court has asked for you to come there, evaluate the patient, and talk about the liability. So trauma by assault, trauma in workplace. Let's deal with these two. Trauma by assault, you have to mention the alleged assault, put that on record, and send the details to the patient and to the hospital, to the police department. Now, what you need to have as a checklist is the medical legal register, the details of every injury, whether it is simple or grievous, and the extent or amount of loss of function. Grievous injury, very big chapter in the section 320. These are 4 that relate to us as ophthalmologists. Permanent loss of eye or vision, permanent disability that can involve the face or the eyelid, fracture or dislocation of a bone or tooth or orbital bones, as Dr. Sumit just showed, and any trauma that can endanger life or put you off doing your normal work for 21 days or more. This is really, really important, the 21 days by law. Now, a checklist for trauma, if you have ordered an investigation, make sure you've preserved those records as well, including the films, and a certificate of injury on demand to be given to the patient if it is a simple injury, but if it's a grievous hurt, as I just showed you, it has to go to the police as well. Record every injury, every investigation, every treatment you've done, record whether it's simple or grievous, and the amount amount of loss of function. If it is grievous, mention whether it is mechanical, that is injury, assault, whatever, chemical, heat, or electric. Now, workplace. Workplace doesn't differ too much from assault except for the fact that it will follow the ESI Act. So, extent of loss, find the final loss of function or vision loss or blindness has to be calculated at the end of either the admission period if you have admitted the patient, or the treatment period if you are the treating doctor. So that's the final record. So if you are asked to comment on how much visual loss the patient has, make sure you go back, see when was the patient last seen, whether the treatment was completed. If not, don't give the certificate, say it's pending, call back the patient, reevaluate, reassess, and only then give the certificate. This is roughly the disability. So loss of sight to, goes all the way up to 100%, and loss of one eye could be 40%. These change depending on whether you're looking at NPCB or law, but this is roughly what can be done. Should you take up a case of trauma if you are a general ophthalmologist under the Consumer Protection Act? As I said, you don't have a choice. If a polytrauma patient comes into your clinic, even if you don't know, you don't have an anesthetist or an emergency, you have to stabilize the vitals, and then only you can refer. Make sure that when you refer, the copy of the letter that says you've referred to XYZ hospital is received, and the patient or the relative signs saying received and the date and time that it has to be done, and store this. It will help you. To summarize, this is the safety checklist. Record the injuries in detail, photos and figures. Do the necessary investigations. Keep the records for 3 years minimum, but ideally they say up to 7. But honestly, as long as you can store it, because if a case goes to court, until the court is deposed, the judgment is made, you may require to hang on to those. Informed consent. If surgery is done, treat the patient as per textbook norms. This is the basic definition of negligence. Refer to a higher center when you can't. Be transparent and polite. Mainly, good communication avoids 99% of medico-legal cases. And finally, this legal maxim in Latin says, the ignorance of law is not an excuse. So we must know both our rights and our duties. Thank you.
That was an absolutely excellent presentation, Dr. Anand. Any questions from the audience regarding the two talks that we had, or anything before that? So I wanted to ask you something, Dr. Anand. So if there's a patient who's come with a trauma, and at presentation they gave a particular history saying that they fell down or whatever, and that is what is noted and the MLC is made, if it's a workplace injury. But after a day or two, they come back and they change that history and now say that it was due to someone someone hit them. Should we change what is in the MLC already, or should we leave it? Should we document it somewhere? What is the way we go forward?
Sure. That happens quite often, actually. So in the first case, if it was just a simple hurt and you have just established it in your electronic medical records and your hospital records, then sure. Then the first time you actually lodge an MLC register, that's when you can not change it, but that's when you're first documenting it few days later. But if you have actually done the due process of recording it as an MLC case in the first one, then absolutely don't change it, because you've already supplied the information. Your local police has already come and made a record of your MLC case in what they call the daily register. That gets a number, so-and-so / so-and-so, so-and-so. And that will be produced in court as evidence. And if you then change it, it will be as though you are violating that evidence, and the onus will fall on you. So don't.
The patient is now changing history in the EMR
sure,
or your
that
record?
would be in your hospital records, but not in the medical legal records. That can be added as a separate affidavit saying that this happened, 4 days later this happened, but the original record stays as the original record.
Remains the same, yes. Yeah. Our next presenter is Dr. Anusha Arvind. She's a consultant at Narayan Nethralaya in the Department of Neuro-Ophthalmology, and she'll be talking to us about another very severe and important injury of traumatic optic neuropathy. While Dr. Anusha is setting up, one question for Dr. Sumit. If we have a patient who we are suspecting an orbital injury, okay, is your go-to mode of evaluation always a CT scan, or is X-ray still adequate? Because sometimes they'll say that they may not have money or anything. Is that adequate, or would you always insist on a CT, or how do you go about it?
No, ma'am. The X-ray is the first mode of investigation always, since we need to rule out also foreign bodies here, because even a first case that I showed, a preseptal cellulitis, can have a foreign body behind.
Yes.
So doing X-ray always makes a sense. But in case you see the post-septal part is involved, there is a proptosis, there is a deficit movement, then you will insist for doing a CT scan for sure, even after X-ray.
And is there any difference in your management or time of management, being it a pediatric or an adult case? Does that have any bearing?
Yes, ma'am. But like I showed, the pediatric generally present little later. But if once I see, then it becomes an emergency because there is a trapdoor
Yes.
either, or patient has a bradycardia and they are not able to complain about all that. Then of course the pediatric becomes very much emergency in such cases.
Right. Thank you. Over to you, Dr. Anusha.
Thank you, Dr. Sharon, and thank you to AIOC for the opportunity. So this would be another aspect of trauma. Sometimes patient is also in plight, and we are also in plight dealing with traumatic optic neuropathy. But let us take a look at what are the management options and a few cases that I have put up. So coming to trauma, like everyone has said, so the insult to the optic nerve, unfortunately, sometimes because the optic nerve doesn't have a capacity to regenerate, ends up being a permanent vision loss. But depending on the type of trauma, it can be there can be a variability in the vision loss. So the site of injury can be either in the optic nerve head, in the intraorbital segment, in the intracanalicular segment, or even in the intracranial portion of the optic nerve. So the mode of the injury can be a direct, where there is a traumatic optic nerve avulsion, that is the fibers are lost, or an indirect optic nerve, that is via the coup and contra-coup mechanism, where there is a transmission of the forces from a distant site. So as we all know, there is an injury to the optic nerve, then there is there's a swelling, and this sets up a compartment syndrome, which further compromises the blood supply to the optic nerve, leading to apoptotic cell death. So the diagnosis of traumatic optic neuropathy, we do need to rule out other causes of optic neuropathy. Many of our patients are diabetic, hypertensive. They could be having a pre-existing ischemic optic neuropathy with a coexisting history of trauma. And we need essential neuroimaging in the form of CT or MRI. We need a proper clinical assessment, and we need to also look for associated intracranial traumas, because it may not be important to manage the traumatic optic neuropathy when the patient is having an intracranial bleed. So at this point, we need to rule out intracranial trauma and refer the patient to the neurologist or the neurosurgeon, and you need to manage accordingly with the neurology team. Okay. So coming to the first case, this is a 22-year-old male who had a tire blast injury, who was not wearing any protective gear on the face, and he had immediate loss of vision post-trauma. So the right eye was no perception of light, left eye was 6/6. So here, this is the right eye where he had a shearing right from the mid portion of the intraorbital to the intracranial portion of the optic nerve. So all we can see is the left optic nerve is normal, and the right optic nerve, there is increased cupping and pallor of the disc. So in this case, this patient was seen in the army, and he didn't have immediate access to medical facilities. So nothing much could be done about the optic trauma per se, except he received a dose of IV methylprednisolone, but of course he did receive it in the appropriate period, but didn't have any improvement. So the next case is a 28-year-old male who was just a bystander on the road, who was hit by a heavy motor vehicle. So the mechanism of injury also plays a very important role in most of these patients. So unfortunately, this patient had a bad hit to both his eyes. The right eye was a thusical eye with a globe rupture and a vitreous hemorrhage. The left eye, he developed a traumatic retinal detachment with a membrane on the optic nerve with an avulsion. So this basically is the left eye showing a lot of glial tissue proliferation with the optic nerve head avulsion, and both eyes he had no vision. But at this time, it may feel like in vain because the patients keep asking what else can be done. But I think as a medical personnel, we are also entitled to say when there is treatment and when there is no treatment, because giving treatment might do more harm than then help the patient. Because putting this patient on a dose of high dose steroids might lead to worsening of or creating an endophthalmitis or a panophthalmitis. So the third case is basically, I've just put it up to see that not all optic nerve injuries or not all nerve injuries might be a traumatic optic neuropathy if there is a relative afferent pupillary defect. So this patient was a 25-year-old male who had a two-wheeler on two-wheeler collision. He had traumatic brain injury with multiple facial fractures which had been repaired elsewhere. And his vision in the right eye was 6/18, left eye was 6/6. The color vision was in the right eye 12 plates, the left eye was 21 plates. So many patients who come may not have a clear-cut afferent pupillary defect. Most of them have an coexisting traumatic mydriasis or an associated third nerve palsy with ophthalmoplegia. So we need to do a reverse RAPD to check if there is an afferent pupillary defect or not. So in this patient, obviously the afferent pupillary defect was there, but it was not coherent because in a traumatic optic neuropathy, you get a full-blown afferent pupillary defect when they have a loss of vision. So he had a partial ophthalmoplegia. So what he actually had was a submacular bleed. So this was referred to the retina and he underwent pneumatic retinopexy. So not all afferent pupillary defects, we have to correlate with vision, color vision and the rest of the retinal findings and make sure that it is only a traumatic optic neuropathy that we are dealing with. And the next patient is, I just want to show this. So basically he had loss of vision in both his eyes. As you can see that the left eye has a bit of anisocoria compared to the right eye. The right eye is reacting but sluggish. The left eye, you can see the afferent defect very clearly. So he was sedated and he had a history of assault and he had multiple intracranial hemorrhages and he underwent decompression craniotomy. So the right eye vision initially on assessment was 660 and the left eye was a no PLI. Both eyes, of course, he has an advanced optic atrophy. But this patient was given only conservative management, and as you can know, there is some amount of natural recovery also that happens in traumatic optic neuropathy, and he improved naturally to 615. So the importance is to look for any segment of a bony fracture impinging on the optic canal, to look for any intracranial pathology like bleeds, and always do visual field assessment in the other eye because the other eye might have a hemianopic defect because of an intracranial bleed. So there are many indirect mechanisms of indirect optic neuropathy. So if the angle is between 0 and 45 degrees, the damage is more severe than if it is between 90 and 180 degrees. So it is important to know what type of impact it is, and the most common segment is the intercanalicular segment where there's tugging between the brain and the optic nerve. So this is one human model that has been studied which showed that at the angle of 0 and 45 degrees was the maximum impact of traumatic optic neuropathy. So the treatment can be observation, high-dose corticosteroids, erythropoietin, surgical or experimental things. There's still no conclusive or reliable evidence on the management of optic neuropathy. So there are many studies with high-dose steroids, but these are controversial. Sometimes they say it's best left alone, but if there is intrasegmental edema, we can go ahead and give the steroids. Erythropoietin has been tried. There are a few pilot studies where they've showed that there is some amount of hypoxia and reduction in apoptosis with erythropoietin, 3 days of 20,000 international units of erythropoietin. Optic nerve decompression, definitely if it is within the first week of optic neuropathy, preferably in the first 3 days, we refer to a neurosurgeon to do the optic canal decompression and optic nerve sheath fenestration. And there are a lot of experimental evidence on multiple molecules that have been investigated for optic neuropathy, like glutamate antagonists, anti-inflammatory cells, stem cells. Hypothermia is something that people are trying out, and certain lipids, because the optic nerve is made of a lot of lipids, and implantation of mitochondria. So thank you so much.
Thank you, Dr. Anusha. I know it was a very large topic to cover, but so often these are things which confuse us as to what we should be treating. I now move to the last talk of our IC, which is a slight difference, a little step away from what we do in our daily practice. It's on artificial intelligence in predicting trauma and its severity. So over to you, Dr. Gairik. Dr. Gairik is a consultant with us at the cornea department, and he has a lot of work in AI. So just before everyone is leaving, I hope you'll found this IC useful. And if you did, please give your feedback. And if you have any questions beyond this or any suggestions on how to improve, we would be happy to have your feedback. I think they're going to be sharing an email with you all. Thank you.
Thank you.
Over to you, Gairik.
Thank you, Dr. Sharon and AIOS for the chance. So I'll be quick and brief. Majority has already been covered. So I think the burden of ocular trauma is something which is well known. There are so many factors which affect outcomes. We've spoken about the extent of injury, presence of cataract, posterior segment involvement. But what we wanted to do is, in our own center, our center being a referral center, invariably a lot of the cases are referred. And what we wanted to do is look at what are the factors which kind of can predict their outcomes in, after 1 year, after 2 years. And finally, it's important that these are medical legal aspects, and then prognosticating them is something very important in our scenario. So we did look at classical variables preoperatively, which were, known. You're of course looking at the extent of the wound, the vision, looking at RAPD, posterior segment involvement. But what I did a little differently in our database is, look at demographic profiling, and that is something which is missed in Indian context. It's important to understand that many of the patients do come, workplace injuries are workers, socioeconomic profiling is something very important. And invariably, many of these patients are referred multiple times. They go to one doctor, go to another doctor, then come finally to that. And does that affect? We know it does, but I kind of wanted to prove it at our level. So I used an AI model. You can use multiple ways of analyzing it, but what AI helps us is it helps me look at multiple time points, stratifying the risk factors, and kind of gives you a cutoff score. So, you're looking at the age, you're looking at the time, or you're looking at various factors. AI kind of gives you a star. So I looked at almost 1,324 eyes. We kind of categorized it into good or bad at 2-year outcomes. So they at least had 2-year follow-up. And these are patients over the last 10 years operated at our center with multiple surgeons, of course. And we kind of utilized a model which is known as a random forest classifier. I will not go into the details of that for want of time, but it's important to understand there are various ways of looking at AI, but the way we still do it is still, the basic steps of creating an AI algorithm still remain the same, where we are kind of putting in the data set, implementing a model, and then kind of visualizing the results. So the AI, in fact, had a very good accuracy in, kind of classifying these patients based on preoperative factors. Interestingly, of course, a male preponderance is known. That is something which Dr. Anand also spoke about. But when you're looking at pediatrics, it can be a confounder because ours is a referral center. Maybe that might be the reason. But over 40% of the injuries in the last 10 years of the 1,324 eyes tended to be pediatrics. Now, AI accuracy was good. You're looking at the area under curve. But what I wanted to kind of dwell at is the first parameter detected was, of course, pediatrics. And that is, in fact, known. You might require multiple surgeries. General anesthesia is always an issue. You don't intervene early, endophthalmitis, that plays an important role. But the second factor, what I wanted to highlight, is the fact that majority of these patients which we looked at in the last 10 years had a time to the hospital interval of 4 hours. And that's kind of important because it correlated very well with the fact that these are the patients, 70% of whom had more than 2 referrals. And that is, I think, a challenge because, see, we already know the various factors which were dealt with in the trauma. You're looking at counseling, you're looking at triaging, you're looking at intervening. But what is sometimes seldom not done adequately is that you refer the patient to the right person at the right time. And that's something very important. And that can kind of reduce the time it actually takes to get that primary intervention. So we cannot obviously change the known factors or non-modifiable factors. Cataract present being, preoperatively, we can't change that. If it's a large corneal scleral tear, we can't change that. But what we can dwell at and kind of intervene at our level, even if you're not in an institute and you're planning to refer, is talk to the referring doctor and refer at the right time. Because what AI picked up is patients who had multiple referrals tended to have worse outcomes, and that was one of the top 3 parameters detected, and that is a little worrisome, right? I mean, after so many years, there are so many centers at every district. There should be a better way of triaging and referring. So rest all in terms of how we manage has been dealt with, and this is kind of just to end off the IC in looking at our large database over the last 10 years. Thank you.
Thank you, Gairik. I know how much effort went into collecting and analyzing the data. With that, we come to the end of our instruction course, and I would like to thank all our speakers and, of course, our great audience. Thank you very much. I hope it was useful for everyone.
Thanks. Can we have a photo, Sumit?